This is BBC Two, where we now continue the series on the impact of modern medicine. This week's programme, which includes scenes in an operating theatre, shows how the quest for the cure is overshadowing the need for preventative medicine.
Johns Hopkins, one of the world's premier teaching hospitals, a pioneer in the history of medicine, a mecca of medical science, technology, and education.
All right, can he come on? Can he stop it here? Okay, one after one. All right, one after one. Sorry, I need space. Give me a little room. Space, 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 space.
These are the residents, doctors in training.
Make sure that you tie and everything is being done nicely and neatly.
They've completed 4 years of medical school and are now practicing doctors on the hospital wards. They're the inheritors of the Hopkins tradition, a tradition of medical education which has set the standards for teaching hospitals around the world.
Okay, wonderful.
Today, the Johns Hopkins tradition of medical training is under greater pressure than ever, with hospital wards increasingly reserved for the acutely ill. So these doctors are seeing only the most serious stages of disease and applying the most advanced and costly measures to treat it.
You know where you are? You're in Hopkins Hospital.
You just breathe in through your mouth here. You're going to do fine.
While people from around the world come to Hopkins for specialized treatment, the emergency room is the hospital's point of access for the people of East Baltimore. Here, junior doctors learn to treat cases which require immediate medical attention.
Apparently caught in the crossfire of a shooter.
Take a deep breath and hold it. Shoot an X-ray. Hold it.
Okay, hon. Push very gently. You just push.
But it's not just emergencies that get treated here. This is where poor and uninsured patients who don't have doctors of their own come for simple primary care. With facilities saturated and resources strained, they can wait 10 hours or more to see a doctor. Lilbert Campbell, aged 86, has arrived in the emergency room with multiple complications. He hasn't seen a doctor in years.
Hi, Campbell? Yes. Mr. Campbell? Hi, I'm Dr. Fry. How are you? I'm your doctor.
You're a doctor. Well, I mean, you're a doctor. You can help me in every way.
Okay.
Just like God can help me in every way. You can help me in every way.
Okay.
Well, I'm glad to
You're a son? Mr. Nice to meet you.
Right, doctor.
Hi. Has he ever been in the hospital before?
Dr. Alicia Fry is an intern, a first-year resident. She's in the middle of a 36-hour shift on call.
I'm going to just try to figure out what are his primary problems, see if I can synthesize that into maybe some sort of overlying picture or comprehensive picture and try to do the appropriate test to figure out what's going on and then what we can do to help him. Hey there, can you do the physical exam now? Yeah, if you would like. Why don't you, yeah.
It's with patients like Mr. Campbell who lack private doctors that residents like Dr. Fry get most of their clinical experience.
Mr. Campbell, Mr. Campbell, can you hear me? Do you have a good ear?
Yeah, I told you that it's effective.
Do you hear better out of this ear? Do you hear me when I'm talking?
Yeah, oh, no, sure I can hear you. On this side, there ain't nothing wrong with it. This one,
Dr. Fry can call on senior physicians during the night if she gets in trouble. Otherwise, she's on her own.
You're very scared at the beginning. You're scared to death because it's the first time you have to take on responsibility for a patient's life. You can leave those teeth there.
Tonight, Mr. Campbell will require close attention, but he's just one of 40 patients under Dr. Fry's care.
I don't think it's the ideal way to train. It's very tiring. It makes you a little bitter, I think. You start to look at patients not as patients, but just as a long hit or a short hit. Are they going to be a lot of work? Are they not going to be a lot of work? And yeah, I think the intensity of the program sort of fosters that attitude. It's hard to keep your perspective.
I've never seen it.
The modern teaching hospital is a relatively recent descendant of the 19th century almshouse, where the poor came to recuperate or die. But the doctors went to the homes of the wealthy, often leaving the destitute patients on these wards to be cared for by religious orders. By the beginning of the last century, physicians in France began to come into the hospital to study disease. The hospital became a place for doctors to learn, and the patients on these wards became clinical material for investigation. But medicine remained mostly powerless to cure. With the germ theory, the science of medicine was born. For the first time in history, doctors began to understand the biology of disease. In Germany, the excitement drew many physicians away from their patients and into the laboratories. Vaccines and cures were being discovered. Surgery was being transformed from a perilous craft to a life-saving specialty. The teaching hospital became a symbol of hope for rich and poor alike. Meanwhile, the causes of disease outside the hospital walls were largely ignored by the medical profession. In the United States, Johns Hopkins embodied the newest model for medical training. Founding physician Sir William Oursler brought together the art and science of medicine. But laboratory research and specialization soon took center stage. Hopkins became a temple of science, and this new model came to dominate medical training around the world.
En la fecha del 18 de julio, Su Excelencia llega al nuevo edificio acompañado por varios ministros del gobierno.
By the middle of this century, the acute care teaching hospital became the centerpiece of medical systems everywhere. In many countries, like Franco's Spain, basic health care became secondary to these costly symbols of medical progress. Internationally, this model dominated medical training. Today, such hospitals care for only the sickest 1% of all patients who are ill. Yet this is where 90% of medical training takes place.
Well, we need technology, we need specialization, we need the kind of care that's given here, but it's a very small spectrum of the total range of disease problems in the community and the population. And to educate medical students and train residents who have as their sole exposure the kinds of patients that are seen here is to distort the picture of medicine.
Yet physicians continue to be trained in hospitals where they're exposed primarily to serious and sometimes exotic diseases.
Ms. Soubic? Good morning. Can you say hi to us?
Helen Soubic is a diagnostic puzzle.
Hi.
Craig Basson is the
Good.
intern on her case.
How are you feeling?
Okay.
Are you in any pain?
Only 3 weeks ago, Helen was in good health, but then her condition rapidly deteriorated.
Not that I can remember.
Okay, good. you know where you are this morning?
Mm-hmm.
Where are you?
Helen Soubic entered Johns Hopkins with one of the highest white cell counts in the history of the hospital.
When I brought her here, initially, she was still coherent.
Helen's daughter, Carla, is a nurse.
But within 2 days, she couldn't move her arms or legs, couldn't see, and was mentally declining. She's had numerous tests done, and we've really not learned much about what's wrong.
Well, she's had the more than $1 million workup at this point. She's had multiple X-ray studies of her head, including standard X-rays, CAT scans, MRI scans. She's had multiple invasive procedures at this point. She's had 2 spinal taps. She's had a liver biopsy. She's had muscle biopsies. She's had skin biopsies, as well as a whole host of other X-ray studies, CAT scans of her whole body, really.
The next thing I'm talking about is doing a brain biopsy. But I don't think they're real hopeful about that.
Okay, so after the brain biopsy, then what are we going to do? Just what the heck are we going to do?
I think, you know, at this point, I don't, you know, we've gone round and around. I don't think any of us have a clue as to what's going on with this lady. I think we were all in agreement that the brain biopsy is likely to be low yield anyway, but it's really the only thing we've got left.
Yeah. Okay.
Neurosurgeon Dr. Sumio Uematsu has come in to evaluate Helen Soubic for the brain biopsy operation.
Dr. Uematsu.
This is Dr. Uematsu.
Okay.
He's the one that would be
All
doing the biopsy if we agree to it, okay?
Okay.
All right.
So if you have any questions and you think of them, then, okay?
Okay.
All right.
Okay, I'm not decided to yet
Right.
how to approach this. I just saw the film, and there are multiple areas, many areas. But most likely I'm going into the right side, in the front. That area brains more. That's we call silent area. In other words, we can remove that area without causing paralysis or anything. How many fingers here? How many fingers? Can you see it? Can you show
I
her
don't want to
something?
do something wrong.
Yeah.
You're doing fine, dear, okay? You're doing absolutely fine. You're not doing anything wrong.
Do you know what color my shirt is? Just tell me what color you see.
Black.
I have a lot of questions. Some things I don't understand, such as why they're doing it. I feel like it's not going to show anything that hasn't shown in any of the other tests. She's had tests of her spinal fluid, which comes from the brain, and if something didn't show, I don't know what they hope to gain by cutting open her head and taking a piece of brain out.
Some of her neurologic findings, many of us were confused by till some of the senior neurologists came by and explained to both the interns, the residents, the students, and the attendings exactly what they meant. And so she's really been very educational for all of us.
I can't help but think that maybe it's 50-50, that yes, they want to help her, and yes, they want, for their own benefit, to know what's going on, just for the intellectual aspect of it.
The doctors now seem relatively certain that Helen Soubic should undergo the brain biopsy in the quest to diagnose her rare condition.
The medical students are taught to look for rare diseases. I recall one professor telling me, take a good look at this, you'll never see another one. What's the point of looking at something you'll never see again? What you need to be able to cope with is the general problems, the everyday problems that people suffer from, complain about, and which, if neglected, end up in places like this.
Hello?
It's 11 p.m. Dr. John Towns is on call with medical student Sanjay Marwa.
Okay, thank you. Towns.
Their third admission of the night has just arrived in the emergency room.
What's that? How's she doing?
She ain't doing too well.
No.
She looked better when she first came in.
Hi. I'm Dr. Towns. How you doing?
Isabel Humbles was brought to the emergency room by her
Good,
sister.
huh?
She has acute medical problems stemming from drug and alcohol abuse.
This woman has liver disease and cirrhosis, basically, from alcoholism. Got massive edema. She has swelling in her abdomen, which is compressing her lungs, and she's having trouble breathing. She's having intense abdominal pain, gastrointestinal bleeding. She's not urinating anymore. She's not oxygenating well. Thankfully, she still has a blood pressure, and she's mentating okay. But she is extremely ill, and before I take her up to the floor where I'm going to be by myself, I want to make sure she's stabilized at least and we know what's going on. It did come on all of a sudden. What were you doing when it came on?
Laying down.
Laying down? You were asleep?
Isabel Humble's immediate medical problems resulted from not having taken her medication for 3 weeks.
Did Dr. Krasner take you off the other medicine? So you stopped taking your medicine because why?
I wasn't at home, Daddy had it with me.
Mm-hmm. Well, sometimes this kind of thing is, it can make you mad in the middle of the night because you all of a sudden have to take care of this person who's so sick, and it's a lot of work, but this also can be the thing that makes you want to do it because you take somebody who's so sick and you make them better and you make them feel better. And, so I have mixed feelings about it.
Okay, honey. Okay, you're on the bed. Yeah, can you call oxygen therapy, please, and tell them we need oxygen 4 liters for this new lady, please? Okay.
Hurts there?
The fluid buildup in Isabel's abdomen is the result of her liver disease.
Anything make it better?
I get something for pain.
When you get something for pain?
Make me go to sleep.
Uh-huh. I think she'll feel a lot more comfortable when we take some fluid off. Her prognosis is extremely poor. She has end-stage cirrhosis. She's having gastrointestinal bleeding now. Apparently acute renal failure. She's anuric. She's got multiple problems, and I don't think she's going to live very long, but we can probably tune her up a little bit and get her out of the hospital. When patients come in, they can often come in very sick late at night. For some reason, they always come in late at night. She's going to be quite a bit of work. I might not get any sleep at all. Probably won't.
Dr. Fry is on her way to the outpatient clinic, the only place in the hospital that deals with basic problems of everyday medicine. Last night on the ward, she had 4 admissions and 2 hours of sleep.
It's hard during your internship to not feel pressed for time, and so I think clinics are a little more stressful because they definitely pull you away from you have so much responsibility up on the wards, they push you away from the ward.
Dr. Dan Sulmasy teaches outpatient medicine in the clinic.
This is Pauline Blackwell. This is Dr. Sulmasy.
How are you?
Pauline's one of my longtime patients with bad asthma.
He's a Hopkins graduate, but he's critical of some of the training program's priorities.
I think that sometimes we have too much of an emphasis on the very, very sick patient. I mean, it used to be said, I think, that the best way to learn medicine is to care for absolutely the most sick patients, the way we do in the inpatient unit. But I think that's simply not true. That learning to care for somebody who has exfoliative dermatitis, where their skin is, coming off in sheets because they've had some severe drug reaction, the kind of rash you'll see in the inpatient setting, doesn't prepare anybody at all to know what to do when somebody comes in with eczema.
The way we educate physicians is out of sync with the problems they have to face when they go into practice. A significant number of the problems that end up in the hospital, somewhere around a half, are preventable. That is, by the time the patient ends up on the inpatient service, they have a problem which, if appropriately addressed in the clinic, for example, or if appropriately addressed with preventive measures, that hospitalization could have been avoided, and the degree of illness that that patient manifested in the hospital could have been avoided.
Have you gained weight? You feel like you're gaining a lot of fluid weight?
Yet preventing hospitalization often requires the long-term care of patients with chronic conditions, very different from the quick-fix approach on the acute care wards.
You need 2 pillows to sleep in bed at night?
There is a lot of frustration for physicians in dealing with chronic illnesses that are frequently not going to be cured by what's being done. But again, I'm reminded of the sort of ancient medieval aphorism about what the goals are for medicine, which were to cure, sometimes to relieve often, and to comfort always. And I think those are still truly what the goals of medicine are and ought to be, although I think that we've distorted things to the point where we, think we can cure frequently, relieve a lot of the time, and we sort of comfort when we get around to it.
This is Ms. Isabel Humbles. She's a 39-year-old black woman with a 20-year history of alcohol abuse. For the past 3 years, she hasn't been drinking any alcohol, and she has an IV drug abuse history.
Dr. Paul Oursler, a third-year resident, leads the morning ward round. The doctors have been unable to drain Isabel Humbles' abdomen, which is still causing her pain.
But those are the main things. I think that if we were able to take her fluid off, and that'll be a great palliative treatment, and she'll be relieved of a lot of pain.
Unfortunately, a lot of what we do here has to do with people who have had either a problem with alcoholism, drug use, smoking. And in fact, that's another source of frustration to some extent, because you realize that here we spend huge resources in order to take care of the acute problems, and yet we're pulling those resources away from preventative measures which would really work. In other words, we're putting our finger in the dam rather than going back and working on the underlying problem.
Oh! Oh!
Have you had this pain before?
Oh, not like this.
Does the pain go anywhere? Does it go into your back?
Yeah.
Does it go into your chest?
Yeah.
Does it go into your groin down here? Okay, it goes everywhere.
Oh, Lord, help me.
When people get to be adults and they have the habits that they have and live in the kind of environment that they do around here, there's not a whole lot you can do for them sometimes. This woman continues to use drugs in spite of having destroyed her liver with alcohol and other drugs. And there's not much you can do.
Okay, it's going to be some pressure.
The day after her admission, Isabel Humbles has the pressure on her abdomen relieved.
Okay, not doing anything else, Miss Humbles. The needle's in and the fluid is coming out. Yeah, but I'm
Just
bear with us a little longer.
The fluid just coming on its own, okay? We're not
doing anything else. We're just taking off the fluid.
The AIDS ward, one corner of Johns Hopkins where they're trying something new. With special funding for extra staff and resources, they're attempting to give the care which is often neglected within the usual pressurized training program. Physician's assistant Joe Lesley coordinates the AIDS unit. She's concerned about the stress on doctors in training and the impact this can have on patients.
It's like being in a war. It's a very brutalizing experience. They go in to the training one kind of person, and they come out very, very different people. They come out, I think, much harder. They come out having been to war, and some of them are still bleeding when they come out, or they've got pretty nasty scars. And that will show in the way they care for patients from then on.
won't be as bad as it seems.
Sure. Patients get much better care when they are cared for by someone who has been cared for. When you take good care of the residents and the doctors, they feel like taking care of the patients. You're going to be headed out to Project...
Kathy Sanderlin got AIDS from intravenous drug use. She's been in and out of the hospital for more than a year.
Who was looking after you in the clinic before?
Dr. McMahon.
In this unit, the focus is on continuity of care.
One of the things that happens up here is that we have a longer view. And we know that next time, we know where we left off. And we know that we can try again. Because we've got the continuity. We've got the same nurses. We've got the same information. We've got the same clinic. We've got people who will continue to keep reaching out to this patient over and over again. And that doesn't happen on the regular services.
Kathy Sanderlin, birthday today. Placement, somebody from the Project Home was supposed to come by and see her yesterday. I talked with
Here,
her.
an attempt is being made to focus on more than a list of laboratory values.
And just on another note, there's a surprise birthday party this afternoon at 4. So the nurses are bringing big sheet cake and all kinds of excitement and presents, and she didn't know any of that. So she's gotten a bunch of cards and some little bitzels, and she thinks that's all there is. And so if we make a big spoof about birthday and all that kind of stuff, she'll think that's it. And we'll fool her yet again, because this will be her last. 30 day. We are Kathy's family. She's lived with us since the end of June. We see more of them than their families do when they're here. So it only makes sense when you don't feel good that you want to be with your family.
Happy birthday.
Feel good?
I'm at the top of the hill. Y'all, I'm all right today. Miss my legs and stuff is still swollen.
These are people who come from very chaotic lives out on the streets, lots of them. And this is a place where it's safe, where they can get 3 meals a day, where people treat them with respect and look after their health needs.
I'll be back later on today.
You get some doctors that, you know, like, well, she's going to go back out there and do the same thing again, so I'm not even going to waste my time on her. You know, I'll go see her every morning, but still, she's going to come back next week or whatever. But in my opinion, I don't get treated like that up here.
A lot of what I end up doing here is interpreting, if you will, the patients for the physicians, and interpreting and explaining that someone who has grown up with a life of IV drug use is actually a successful person. That's a person who survived. That's a person who survived a life that we cannot even imagine. A life in the inner city of shootings and stabbings and child abuse and drug use all around them. That person's a survivor and successful in that world. And to acknowledge that part of success is very important, I think, in the relationship of seeing that physician and patient are perhaps not so far apart. And that physician can learn an incredible amount from a patient who's lived a life like that.
If some doctors and all would find out what the street life is about, then they would understand why people have HIV, you know.
Happy birthday.
Kathy's 3 children are part of her care plan.
I got a little 5-year-old. She's something else. She's a good kid. All of them good. I got 3. I always say God bless me with 3 beautiful kids.
Kathy's an example of what happens to almost every woman that we have here. There are always children. And you come in and you see a young woman in the bed and you don't think children always, but here you have to. And you have to think children who will be orphans.
Put my green one up there. That's it. Oh, made Mommy Wall look good. I'm at the top of the hill if somebody asks you, okay? I haven't fell down it yet. If somebody asks you how old your mother is, you tell them she's at the top of the hill.
Back on the general medical ward, Isabel Humble's family comes to take her home.
People should have gotten taken care of a long time ago, before they got here. We're at the end of the line taking some care of some of these people who who destroyed themselves, and by the time they get here, it's too late. So sometimes I feel like we're missing the point. From what I've talked to her and her family, I know that she comes from a very difficult environment. She lives in a place by herself. Family members drift in and out. She doesn't have a stove. She can't cook food for herself. The night before she came in, she was sniffing cocaine. I sort of feel helpless to do anything.
Isabel will return to East Baltimore, where there are no openings in long-term drug treatment programs. Garden of Prayer Baptist Church, one place where the healthcare problems of the community are beginning to be addressed. Minister Reverend Melvin B. Tuggle leads the Heart, Body and Soul Project, which provides preventive medicine where conventional healthcare has failed.
I want to preach from the subject, and I want you to help me this morning. Is there a doctor in the house? Y'all don't hear me. Is there a doctor in the house? One of the most needed professions in the history of mankind is that of a doctor. Do I have a witness? The closer we get to John Hopkins, as you notice, the more the health problems become more viewable. You're seeing people on the steps early in the morning with beer bottles, wine bottles. This is Dope City.
Added to an epidemic of drug-related disease, East Baltimore has one of the highest rates of heart disease and stroke in the United States. People here are almost twice as likely to die from these diseases as the general population, and they're twice as likely to be uninsured.
We can compare this area right in the Hopkins corridor with third world countries. Hopkins need to do more, and also the community need to do more. And we're hoping that through Kerr and through the Heart, Body and Soul Project, that we will become more of a partnership in cleaning up this East Baltimore area medical problem.
So could you take a deep breath? 1, 2.
So, in conjunction with Hopkins staff, Reverend Tuggle helps set up Sunday clinics in churches throughout East Baltimore.
9, 10.
I do not believe that house staff in training in general want to come out to the community. I don't think that their training sets them up to want to come out that way.
Diane Becker is a health expert from Johns Hopkins who works with Reverend Tuggle to bring medicine outside the hospital walls.
Unless you understand the culture, you don't understand the conditions under which patients have to take insulin, the conditions under which patients have to select their foods to eat. You don't understand the economic resources that are available to them. And you may not understand support systems that are available that could be mobilized.
But your doctor's never really talked to you about cholesterol before, right?
No.
Okay.
If you came back and you stopped smoking, we could get the carbon monoxide out of your system in a very quick period of time, a couple of days. We could get it out. Okay, good. Now, did you get one of these? Okay, the kinds of things that you eat?
You're going to feel pressure, just pressure.
A good doctor will have in his or her possession a blood pressure cuff, which is used to monitor a person's blood pressure. For if our pressure is too high, it could lead to having a stroke. It could lead to a heart attack. Well, as Christians, we must possess our own spiritual blood pressure cuff. You have a witness? People have lost their faith in doctors. I'll be very honest with you. They do not have that, the old family doctor that maybe worked the whole neighborhood. People place their faith in him or her. Now with high-tech modernology, computers, etc., into the hospital, people have now become a number. It's machines that work on them. Doctors do not work on them. The personal emphasis is gone now. Everybody is a specialist. We have a specialist for this and a specialist for that. And when you go see the doctor, nobody has sense enough to take your children. Nobody has sense enough to give you a couple aspirin. So as a result, the people have lost their faith. They lost their faith in the care, and they lost their faith in the physician. It's a terrible thing. We need hands-on, walk-the-street doctors, neighborhood doctors. At one time, we had a lot of practices in East Baltimore. It's gone now. It no longer exists. Doctors are scarce. A family doctor can't make money anymore. And it's a general practitioner, I should say, is out because of the money. Everyone wants to be a specialist. The health system of these United States has gone to pot. You can't get help unless you have money in your pocket. Something is wrong. Do I have a witness? So I asked the question this morning. Is there no balm in Baltimore? Is there no physician there? In other words, is there a doctor in the house? Yes, there is.
Can I turn this light on here? This is the rest of the doctors I work with, Mr. Campbell. All these people here. I'm going to tell them your story.
Yeah, you're great.
Is that all right?
What you want?
Okay, this is Mr. Campbell. He came to the emergency room yesterday, which was 1 month after he had a facial laceration repaired in the ER. And his family reported that he had some worsening mental...
Lilbert Campbell seems to be responding to treatment, and although doctors suspect that he has prostate cancer, they hope he'll be able to go home soon.
I actually enjoy patients like Mr. Campbell because he's a pleasant sort of person. So I can't say he's frustrating to me in any way. I mean, socially, he's got a good social network. He's a very pleasant person. He looks like he's improving, so who could ask for more?
How are you feeling?
I told you I feel much better than what I was. Getting better all the time.
Hoping to go
I
home?
hope I continually feel better.
Pardon?
I said, I hope I will continually feel better like I'm going on now. You all look like you got me going on pretty good so far. Thank the Lord for that.
Are you hoping to go home soon?
The following day, Lilbert Campbell died.
Last Saturday night, I was told he had chest pain, and it ends up that he had a very big heart attack that actually probably destroyed most of his heart. You find out pretty quickly that a lot of medicine is like that. And even a lot of our so-called therapy is not really based on any well-researched what do I want to say, well-researched project or a study, a well-thought-out study. We do a lot of things empirically, and we don't really know. I mean, there is a lot of uncertainty in medicine. I guess it surprised me at first when I was a medical student, but it sort of comes with the territory now.
You have to survive with uncertainty here, and that uncertainty can be physically awful. So people develop whatever mechanisms they do to live through it. We don't acknowledge how much a physician has invested into a care of a patient. You don't know what went on in those wee hours of the night as they sat there by the bedside trying to keep that patient alive. and you don't know the emotional bond. Even they don't know the emotional bond that was made with that patient.
Surprise!
Surprise! Oh, that's so nice. Happy birthday. Thank you. Oh, y'all so sweet.
Happy birthday to you. Happy birthday to you. Happy
The AIDS epidemic is beginning to teach doctors that there are limits to medicine, that chronic and incurable conditions require more than just science and technology.
Oh, yellow, my favorite. Oh, look, yellow.
It feels wonderful to be able to give somebody some normal stuff.
And my favorite color.
I mean, we all had 30th birthday extravaganzas, you know. It's wonderful to be able to give that to somebody and to have some celebration, because up here, we've known her so many times when she didn't care and when she could hardly wiggle. She was so sick.
Ooh. And it's heavy. Oh, Glenn, come on, let me give you a hug. I'll give you a hug, dear.
Happy birthday, Sue.
Thank you, dear.
There are certain times you just want to keep every single patient, and, you know, that's just not part of the business.
Just pop it in and make a wish. Happy birthday, Catherine.
Thank you, dear.
You hold your head real still. Okay? All right. Otherwise, the picture's going to turn out and we'll have to go through this again. Oh, God. Okay, just hold still.
Helen Soubic receives another CAT scan of her brain. This will be used to help guide a special robotic arm in a new experimental surgical technique.
Well, this is a very interesting case because hopefully with this technique we have a chance of making a definitive diagnosis. As I've been talking about with Ms. Soubic's daughter, this technique is more sensitive than a lot of the other techniques that we've been using. It's riskier, but it's a more direct approach to exactly what's going on in her head because we can actually look at a piece of her brain. And hopefully it'll provide us with some answers, and that's certainly very exciting.
This is the abnormal area of brain, and this is the target site. This is the area outlined by X-ray contrast. Front of that is the critical motor cortex. In other words, if we damage this portion, patient might get paralyzed. Then make a photo on the top. Make a drill hole there.
Dr. Umatsu is using the computerized robotic arm guided by the CAT scan to locate the damaged area in Helen Soubic's brain. This technique has been used only 7 times before.
Need some juice, Lisa.
Intern Craig Basson has come up from the ward to observe the procedure.
They've been able to create a three-dimensional image based on the CAT scan this morning of the external surface of her head as well as the entire brain throughout the head. And simply by moving a cursor around on the screen, the way you would on your computer at home, they can rotate the image, dissect down in the image. So Dr. Umatsu is really very accurately able to locate the lesion that we're looking to take out here.
Here's the lesion, right?
Yeah.
You can see that one clearly.
You can see that the blood vessel is a nice cherry red, but at some point becomes a little grayish looking. And that's probably a disease in the vessel, and the infarcted area is that area that Dr. Umatsu is pointing to. How you doing? Definitely close behind you here. I just left the OR. They were closing up there, and everything went fine. Everything went very well. We've just got the cultures downstairs. The brain biopsy is in pathology. There were some findings, grossly, that look like clear abnormalities. We don't know exactly what those mean yet.
And we'll find out if her speech has been affected.
When she wakes up.
Okay.
When she wakes up.
All right.
If what?
When she wakes up.
If
If her
what?
speech is affected.
We'll see.
It's just so overwhelming that in this day and age, with all the technology that they have, that something like this can happen that they don't know what it is. I mean, every day I sit and think, I just cannot believe it. I just cannot believe it.
In fact, the brain biopsy produced no helpful information. But before she left the hospital, Helen Soubic began to recover by herself.
Mrs. Soubic, at the same time as being a very educational patient, very exciting patient for us, is a very humbling patient. Here's a woman who, in the course of days to weeks, has basically lost a good part of the function she had prior to her disease, and we're really at a loss to make a diagnosis. And that's a very humbling experience.
I'm glad to see she's getting better, but certainly after all she's been through, you kind of expect a little bit more, like for them to be able to tell you why she's getting better or how much better she'll get or what caused it.
Okay, keep moving, please. Keep moving. Okay, now the hands nice and knees in front. Okay.
I can't say I have had anything really negative, but I need to step back and look at things.
Ready? With a beautiful, yes, Dan, yes.
I think in the end, after it's over, you look back and you say, well, I'm glad I'm that much better for having done it. But while you're going through it, it's not very much fun.
Okay, now. Pay attention. I have a lady, she said, I'm here, can you see me? Oh, yes, I love blonde hair.
The function of medicine is not to relieve the human condition of the human condition. We can't do that. We're not about making people immortal, and we can't.
Okay. Yeah, fix it. Good. I'm gonna fall. Good.